This video describes phacoemulsification procedure in grade 2 nuclear sclerosis. Yes, the technique of phacoemulsification is fairly standard and widely followed, but there are certain finer nuances to each step which aid in performing a repeatable, safe and efficient surgery. These are mostly few tips that I learned from my mentors and would love to share with novice surgeons. We start by making side port incisions with MBR blade, 2.5 clock hours each from the intended main wound. We use ophthalmic viscosurgical device such as sodium hyaluronate 1.4% into the anterior chamber. This cohesive OVD flattens the anterior capsule. For the main wound, we use a 2.5 mm width keratome blade. First going perpendicular to the cornea 200 to 300 microns, then making it flat to the surface in order to create an intrastromal tunnel of about 2 millimeters, and then slightly changing direction downwards to enter into the anterior chamber. This will create your triplanar incision that must be nearly a square for it to be stable and astigmatically near neutral. For capsular rhexis, we start by raising a flap with the help of cystitome, followed by the rhexis forceps. We use the Haldipurkar forceps, which works very well for even 2.2 mm phaco incisions. Rhexis forceps is a great tool and we use it for every case because it gives excellent control. Try to grasp every 2 to 3 clock hours and keep the size of rhexis 4.5 to 5.5 mm. For hydrodissection, we first remove some amount of OVD from the anterior chamber. We then take the hydrocannula underneath the rhexis margin till the equator and tent the capsule up slightly. Now we inject a bolus of fluid and see the wave form and go to the opposite side. We then tap and press down to release some fluid from the other end. For rotation of the nucleus, it's a good practice to bury the Sinski tip underneath the rhexis margin just anterior to the equator of lens. Rotate putting posterior pressure. Trying to rotate anteriorly will not exert as much force and may even put undue stress on zonules. So go beyond the rhexis margin close to the equator as shown and do give posterior and rotational force. Now, nucleotomy, which is one of the most crucial steps in phacoemulsification. We start by creating a small central trench of depth 1.5 times the diameter of the phaco tip. Now let's see the technique of vertical chopping. We keep the tip bevel horizontally oriented and bury until the entire exposed tip, which is usually 2 to 2.5 millimeter, is completely within the mass of the nucleus. The site of burying should be 2/3 the depth of the nucleus. The second instrument we use is the chopper, which is a blunt tipped 2 mm long Sinski, which works really well for all kind of cataracts, even hard cataracts. The chopper should be placed behind the rhexis margin, diagonal to the tip, and now with the foot pedal in position 2, we raise the buried phaco tip slightly up and move the chopper vertically down and towards the tip. With the crack complete, we take the tip of chopper through the crack at deeper and deeper levels until a complete separation of pieces is achieved. To achieve a good chop, it is important to take the chopper posterior to the rhexis margin and initiate the crack from there. Phaco tip must be buried till the sleeve for an excellent hold. If the hold is lost, we can re-bury the tip and continue the process. The power and vacuum settings have to be changed depending on the grade of cataract. For nuclear sclerosis grade 2, we keep the power around 25 to 30, vacuum around 350 and aspiration rate around 20 for chopping. Making smaller and smaller pieces, at least 6 to 8 is preferred so that emulsification is easier, faster and with least damage to the endothelium. For emulsification, we try to reduce chatter by keeping the pieces held at the tip. We try to be away from the endothelium at the central safe zone. We can use the second instrument to feed the nuclear fragments into the tip. Use dispersive OVD intermittently to protect the endothelium. It's also a good idea to put some OVD beneath the last piece before emulsifying it, especially in hard cataracts, to protect the posterior capsule by keeping it at bay. For cortex removal, we use bimanual irrigation and aspiration. The key is to start subincisionally when the anterior chamber is still filled with viscoelastic. Increase the vacuum slowly after getting a hold. Try to disengage with gentle to and fro movements as shown, and then increase the vacuum as you pull the cortex tangentially to minimize the stress on zonules. For lens implantation, key is the loading of the lens. We can perform wound-assisted implantation as shown here, or we can allow the tip to enter into the anterior chamber and then slowly inject the IOL. Another good practice to follow is removing OVD from behind the lens in every case as shown. This might appear intimidating at first, but once we start doing in first few cases, it becomes just like any other step. Nudge the IOL with irrigation and keep the aspiration in front of the IOL. Finish by hydrating the side ports and injecting intracameral antibiotics. Thank you for watching and stay tuned for more such surgical videos.